Welcome back, everyone. I am delighted to introduce our next speaker, Dr. Yiping Sun. Dr. Sun is an assistant professor of medicine at Harvard Medical School and the program director of the Cardiovascular Disease Fellowship at Brigham and Women's Hospital. His clinical interests include valvular heart disease and echocardiography. Dr. Sun will be giving us an update in atrial fibrillation. Please join me in welcoming Dr. Sun.
Great. Thanks for having me back again. So I'll be giving you a consultative cardiologist view on atrial fibrillation, so trying to avoid the electrophysiologist perspective. Let's see if I can advance. Give me 1 second. I have no relevant disclosures. So this is going to be case-based, and really the learning objectives are that I hope by the end you'll be able to appropriately manage thromboembolic risk in patients with atrial fibrillation, effectively rate control patients with atrial fibrillation, understand the impact of lifestyle modification on atrial fibrillation, how to utilize cardiac CT as kind of a novel imaging modality in the exclusion of left atrial appendage thrombi prior to cardioversion, when to refer patients for an early rhythm control strategy, and finally understand the indications for pacemaker therapy in patients with atrial fibrillation. So we'll start with cases. So the first case is a 90-year-old woman with a history of hypertension that's well managed with hydrochlorothiazide, bioprosthetic mitral valve replacement about 10 years prior for endocarditis in the setting of known mitral valve prolapse, who is now on aspirin 81 milligrams daily only, who comes in with 3 days of cough with upper respiratory symptoms and shortness of breath, who's found to be in atrial fibrillation. She drinks 2 to 3 glasses of wine per week. She remains fully independent and prior to this acute illness was walking 1 mile per day. She has no symptoms of thyroid dysfunction. Here is her exam. She is tachycardic and hypertensive. She's saturating well on room air. She's 50 kilograms. She's comfortable appearing, appears markedly younger than her stated age. If she told you she was 70, you'd believe it. She has a posterior or erythematous posterior oropharynx and nasal mucosa, and her lungs are clear. Her jugular venous pressure is not elevated. On cardiac exam, she is irregular without an S3 or S4. Her extremities are warm and she has no edema. Lab testing is largely unremarkable, except for the fact that her GFR is mildly reduced. An electrocardiogram shows atrial fibrillation without significant ST or T wave changes. Transthoracic echocardiogram shows normal biventricular function, as well as a normal functioning bioprosthetic mitral valve and moderate left atrial dilation. So here's the first question. So in addition to rate control therapy, would you recommend anticoagulation? A, yes, her CHADS VAS score is elevated. No, while her CHADS VAS score is elevated, given her age, her bleeding risk is high and outweighs the ischemic benefit. All right, so clearly everybody got the answer correct. So that means next year I need to update this question. So agree, A is the right answer, and we'll go over why. This question, I think, really gets to the question of whether or not there's an age by which bleeding risk outweighs the anti-stroke benefit of anticoagulation in atrial fibrillation. One of the main criticisms of all the anticoagulation in AFib trials is that while AFib is very commonly seen in the elderly, estimates suggest that up to 10% of patients, more than 80, will have it. These patients are quite underrepresented in these trials. I think clinically, all of us have seen cases of bleeding in elderly patients with atrial fibrillation who are anticoagulated, and I think rightly wonder about the risk-benefit of anticoagulation in this very elderly group. So to really look at this question specifically, I'm going to show some data from a trial of around 15,000 patients with atrial fibrillation who were all greater than 90. Compared them to age and gender match controls and looked at ischemic stroke risk and the risk of intracerebral bleeding. So the reference group here is compared to patients who are not anticoagulated. And the study was interesting because they basically studied before 2011, which was essentially the pre-DOAC era. So essentially all patients who were anticoagulated here were on warfarin therapy. And the top panel is the risk of ischemic stroke, and the bottom is the risk of intracerebral hemorrhage. And what you can see here is really that warfarin was associated with a significant decrease in stroke risk without a significant increased risk in bleeding, even in this elderly group. They then looked at the population after 2011, which represented really the DOAC era, and the top panel is the risk of ischemic stroke compared to warfarin, and there was no increased risk of stroke with DOAC versus warfarin, so really equivalent. And the next panel is looking at the risk of intracerebral hemorrhage, and there's very clearly less risk of intracerebral hemorrhage with DOACs compared to Coumadin in the group. And the bottom panel looks at the risk of any type of major bleeding, where there's really no significant difference. So I think really what this shows is that even in those more than 90, a DOAC still do seem to provide some benefit. While there may be benefit with anticoagulation in those greater than 90, clearly there must be some study, some threshold where the risks outweigh the benefits. So to get to that question, this study is performed. So they took 15,000 patients with atrial fibrillation who were anticoagulated with apixaban and or Coumadin. They generated a model based on clinical risk factors, and the model assumed that each month each patient had a chance of stroke, hemorrhage, or death from a competing cause, and that the likelihood of each was really a function of individual stroke risk, hemorrhagic risk, and life expectancy. They defined the minimally clinically relevant lifetime benefit as 0.1 quality adjusted life years, a relatively standard assumption defined by the solid line here. What they observed is that for Coumadin, shown in the top panel, there was less than 0.1 proven in quality adjusted life years at 87, and then it was 92 for apixaban. And then in sensitivity analysis over a 3-year period, if we remove competing risk of death, there was even more benefit to anticoagulation regardless of age. So I think what this really highlights our clinical gestalt is that they're really 90-year-olds who appear much younger than stated age with minimal comorbidities, for whom really being anticoagulation probably makes a lot of sense. And then they're 90-year-olds who have multiple comorbidities who are going to be much higher risk, and you really shouldn't treat these two patients the same. I think certainly a 90-year-old who's living independently, still mowing their lawn, like a recent clinic patient I had, would be a very reasonable person to anticoagulate versus a 90-year-old frail patient with severe CKD, hip fracture, or dementia, for whom the competing risk probably would be to no net clinical utility to anticoagulation. So are there clearly some clinical scenarios, I think, where it's reasonable to consider foregoing anticoagulation in the elderly? I think there's really clearly evidence to suggest that it can be done safely and is overall beneficial, really suggesting that age alone should not be considered a contraindication to anticoagulation. However, I think you need to use a little bit of common sense, use that finely tuned clinical gestalt that you've honed for over years of practice to really help you make the right decision for your patients. So here's the next question. So what anticoagulant would you choose in this 50 kilogram 90-year-old woman with a bioprosthetic AVR with an EGFR of 45 ml per min over 1.73 meters squared? A, rivaroxaban, B, dose-adjusted warfarin, C, apixaban 5 milligrams twice daily, or D, apixaban 2.5 milligrams twice daily? Not seeing a question here, so I may have messed up in submitting my slides. There it is. All right, so I agree with the majority. I think D is the correct answer. This question really gets to what anticoagulant should you use in patients with prosthetic valves. I think to really answer this question, we want to start by defining valvular atrial fibrillation as atrial fibrillation in patients with moderate to severe or worse mitral stenosis, valve replacement, or valve repair. Patients with native aortic stenosis, aortic insufficiency, mitral regurgitation, or tricuspid regurgitation are not considered to be valvular atrial fibrillation, and therefore can be included in the typical group of patients with atrial fibrillation. It's important to note that DOACs are strictly contraindications when making mechanical valves and should never be used. So mechanical aortic, mechanical mitral valve, those patients must be on warfarin therapy. And DOAC should also not be used in patients who have moderate to severe or worse mitral stenosis, as this is a really highly thrombotic state. So what about using DOACs in patients with bioprosthetic valves? As you're all aware, these patients were excluded in the primary DOAC trials. However, they've been used quite frequently, and so there's quite a bit of real-life data. And shown here is some meta-analysis looking at the role of DOACs in patients with bioprosthetic valves. On the left is the embolic risk, and on the right is the bleeding risk. And what you can see is that DOACs really are a good option, or are probably superior to Coumadin in patients with bioprosthetic valves, both in terms of the embolic risk as well as the bleeding risk. It's important to remember that warfarin, however, remains the anticoagulant of choice among patients with bioprosthetic valves for the first 3 to 6 months, mainly due to a lack of data and the well-demonstrated increased thromboembolic risk during this time period. Whether or not DOACs can be used safely in this time period remains to be seen, though in the real world, many surgeons do opt for DOACs over warfarin in this time period. Certainly after that first 3 to 6 months, DOACs can really be used in patients with bioprosthetic valves. I would say the one exception that I want to make note of, however, is that those for whom the initial indication was rheumatic mitral stenosis, who then get a subsequent bioprosthetic mitral valve, warfarin is still preferred in that patient population due to the atrial myopathy and very high thrombotic risk associated with this disease entity. All right, so we'll move on to the next case. This is a 65-year-old man, a history of paroxysmal atrial fibrillation and flutter, undergone prior ablation, presenting with paroxysmal atrial fibrillation in the setting of an AKI and bowel gastroenteritis. He's very active at baseline, plays recreational hockey, does yoga, jogs 3 to 4 miles, 2 to 3 times per week. He drinks espresso twice daily and 1 to 2 glasses of alcohol on the weekends. He's on apixaban 5 milligrams twice daily, though he has missed a few doses recently, and is also on metoprolol of 50 milligrams every 6 hours. On exam, he's tachycardic to 128 beats per minute. Blood pressure is 110/67. He's saturating well on room air. He has dry mucous membranes. His jugular venous pressure is less than 5. He is irregularly irregular without an S3 or S4. He has no other signs of heart failure. On workup, his comprehensive metabolic panel is notable for an acute kidney injury with a creatinine of 3 milligrams per deciliter. He's hypokalemic as well and hypomagnesiemic. His thyroid function is normal. His blood counts are normal. And his electrocardiogram shows atrial flutter with 2-to-1 conduction. A transthoracic echocardiogram shows normal biventricular function without significant valvular abnormalities. So what would be your next management steps for his atrial flutter? A, increase metoprolol to 100 every 6 hours. Continue metoprolol on L-diazeam. C, continue metoprolol on load with digoxin. D, continue metoprolol on start amiodarone. And E, schedule TE and cardioversion. Perfect. So a nice mix of answers. So I think B is really the correct answer here. You really want to just work on rate controlling. I think for those who have advocated for a cardioversion, the patient is really quite in metabolic disarray right now. He's in acute kidney injury with significant metabolic derangements. And so, if you cardiovert him, it's very likely he'll go right back unless you resolve these. Certainly, if you improve his metabolic state and he remains in atrial fibrillation or flutter, that'd be a reasonable option. But I think at this point in time, really trying to be more aggressive with rate control makes a lot of sense. And this is really a segue to just talking about rate control more specifically. I think in general, beta blockers will be the first line therapy. While there are some small initial trials suggesting harm with the use of beta blockers in patients with COPD, several subsequent larger trials have not shown any risk with the use of cardio-selective beta blockers in those patients with COPD. Based on a small pharmacologic study, bisoprolol actually has the most beta-1 selectivity at 14-to-1, atenolol is next at 5-to-1, and metoprolol is probably the least at 2-to-1. So if you're really worried about airway reactivity in patients with severe asthma, bisoprolol would probably be the best choice. And alternative to beta blockers are non-dihydropyridine calcium channel blockers. The nice thing here is that there's no issue with bronchospasm with calcium channel blockers as well. And diltiazem is also available as a continuous infusion that in many hospitals can be used on the floor setting as opposed to an ICU, which is a nice option. It's important to note that it really shouldn't be used in any patient with significant left ventricular dysfunction due to significant negative inotropic effects. Remember, the dihydropyridines such as amlodipine and nifedipine really don't have significant AAV nodal effects and shouldn't be used for this indication. In addition to beta blockers and calcium channel blockers, digoxin is another option. The advantage of digoxin is that it has no negative inotropic or vasodilatory properties, so it can be used in patients with left ventricular dysfunction or borderline blood pressures. I think the challenge with digoxin is that the therapeutic window is quite narrow, and toxicities can easily develop in the elderly and those with renal dysfunction. It's important to remember that the onset of DIG is quite slow, so it takes more than an hour after IV administration to get any effect, and more than 6 hours to get peak effect. So if you're going to be sitting there giving IV DIG, just know you're not going to see any benefit for a little bit of time. I think the final option is amiodarone that can be considered. So amiodarone is a relatively dirty drug, so to speak. It affects sodium channels, potassium channels, beta receptors, and calcium channels. The rhythm controls mainly comes from the potassium and sodium channel effects, but the rate control is really coming from beta blocker effect primarily. And one thing you need to consider with amiodarone is the risk of pharmacologic cardioversion if the patient hasn't been adequately anticoagulated, as well as some of the toxicities that come when you administer it intravenously. So here are the most recent guidelines for acute rate control. If the patient is hemodynamically unstable as a result of atrial fibrillation, you should really cardiovert the patient. But I think it's really important to distinguish, is the AF the driver for the hemodynamic instability? If they have sepsis from a clear source and they happen to be in atrial fibrillation, that's probably not a patient you want to cardiovert because the driver for the atrial fibrillation is there. Of course, if they're hypotensive because of the atrial fibrillation, then obviously it makes sense to treat that underlying with cardioversion. The next question is really, are they in decompensated heart failure? And by the guidelines, they're really asking, are they in a low output or cold state? If so, you should really use amiodarone and absolutely should avoid diltiazem and verapamil. If they're not in decompensated heart failure, but in compensated heart failure, so warm and wet, so to speak, beta blockers would really be the first option. You should still avoid diltiazem or verapamil if the EF is less than 40%. And if they're in active heart failure, I would still also avoid these therapies as well. Though certainly if you're really reaching, you have no other options. I think it could be something you could consider. In those with COPD, I think beta blockers can be used, though you might want to try a cardioselective beta blocker. In that patient population, digoxin would be the next option, and then amiodarone again. Addition of magnesium is actually considered a 2A recommendation, and so certainly very little downside from addition of magnesium, as many of our patients are hypomagnesium, magnesiemic, and the risk of toxicity is relatively low. In this case, metoprolol was continued, electrolytes were repleted, he was fluid resuscitated, remained in 2-to-1 atrial flutter with ventricular rates. Diltiazem was added, and then spontaneously converted back to sinus rhythm. So really, just with treatment, the patient actually did better and obviated the need for cardioversion. So I think just a few tips regarding rate control. Remember that AFib in the inpatient setting is almost always secondary to some other process. So if the patient is doing okay, I would try and not fixate on an elevated heart rate alone. In fact, I often just try to discontinue telemetry altogether if the patient's doing fine so that it doesn't generate so much anxiety. I would think of it this way. If you had a sick septic patient who was in sinus tachycardia to the 120s, you probably wouldn't worry about it much and just treat the underlying illness and wait it out. I would really think of AFib with rapid ventricular response similarly. I would make sure that the potassium and the magnesium levels are appropriately repleted. I typically do, and I think, whether or not to give empiric magnesium is something that you can consider. You really want to optimize their fluid status. Certainly dehydration or volume overload is likely to worsen rate control. I would say beta blockers or calcium channel blockers as first line, but just be careful if they do have any degree of left ventricular dysfunction. You can certainly combine beta blockers or calcium channel blockers as needed. You just have to watch out for bradycardia if they convert back to sinus rhythm. So the likelihood that this would precipitate a unstable bradyarrhythmia is really quite low. And then amiodarone can certainly be used in hemodynamically unstable patients for whom AFib is not the major driver of their hemodynamic instability. They would just need to consider the risk benefits of pharmacologic conversion. So given how poorly the patient feels in atrial fibrillation, he would like to pursue a rhythm control strategy, but is not interested in additional medication strategies. He's scheduled to see his electrophysiologist an outpatient, but while he's waiting, he'd like to know what he could do to prevent an AFib recurrence. So which of the following recommendations is the most likely to lead to a reduction in atrial fibrillation? A, reduction in alcohol intake. B, cessation of coffee. C, increasing his exercise. D, stopping exercise altogether. Excellent. All right. My questions are clearly getting too easy. I need to adjust things a little bit. So I would say reduction in alcohol intake is the correct answer. And I think I will start with really getting a sense of what are the lifestyle risk factors that are associated with atrial fibrillation, because it's really important for us to discuss this with patients. I think in general, exercise is beneficial across the spectrum of cardiovascular disease, though specifically with atrial fibrillation, it's a little bit complicated. This complicated relationship between AFib and exercise, I think, as well is illustrated in this study. So this is a meta-analysis of more than 600,000 patients over 22 studies, with men shown in red and women shown in blue. The y-axis, the risk of recurrent AFib, and the x-axis is increasing levels of exercise. So in women, there's a reduction in atrial fibrillation with increasing exercise, even amongst those doing really intense endurance athletics. However, the curve is really U-shaped with a substantial increased risk of AFib endurance in endurance athletic men. And so if you have a patient who is otherwise healthy doing ultra marathons, certainly that is something that we would counsel them against, and more moderate levels of exercise would be beneficial. So in general, these are the recommendations that we do. So really just making sure that in women in general, exercise is completely fine. But in men, we really do want to counsel them against very, very aggressive endurance athletics. So I recently had a patient who was 40, new onset atrial fibrillation in the best shape of his life, who was actually doing ultra long distance marathon running, who developed AFib while actually doing a race in Patagonia, and really have strongly recommended to reduce his exercise for this reason. Had an AFib ablation, is now doing well. jogging 5Ks without any issues. So what about alcohol intake? Shown here is data from a study from the New England Journal from about 4 years ago. They took 140 patients who were drinking around 17 drinks per week, who also had atrial fibrillation. They were randomized to abstinence versus the control, so continued drinking as much as you wanted, and they were followed for 180 days. It was a cool study because they actually did a 2-week blanking period after randomization, after which the comparison started to allow for a gradual reduction in alcohol intake. First, what they showed was there was a significant reduction of alcohol intake in both groups. Though the abstinence group went from 16 drinks to around 2 drinks per week, and the control group went from 16 to 13. And shown here is there's really a difference there's actually a significant reduction in atrial fibrillation. So the x-axis here is the days after follow-up, and the y-axis is the risk of atrial fibrillation. And then you can see in the patients who were in the control group, they were much more likely to have a recurrence of atrial fibrillation as opposed to the patients who were in the abstinent group. They had a longer time to first recurrence in the abstinent groups, as well as an overall lower burden of atrial fibrillation. In addition, importantly, about a third of the patients who achieved complete abstinence, they actually had the lowest rates of recurrence, with a 50% reduction compared to those who were still drinking about 1 to 9 drinks per week. So really stopping alcohol completely probably does provide a benefit to atrial fibrillation reduction, though even cutting back will make a significant improvement. So what about caffeine? I think as a stimulant, pathophysiologically, one would assume that caffeine intake would likely increase AF burden. However, the majority of studies have not shown a risk of AFib with regular caffeine intake. In fact, even at high doses of caffeine intake, there's been no association with atrial fibrillation. And in fact, multiple studies have shown that a regular intake of less than 300 milligrams may actually be protective with respect to AFib risk. In terms of how much caffeine is in each drink, shown here is the actually quantities of caffeine and some typical drinks that you might see. I don't think any of us are routinely recommending our patients should start drinking caffeine if they're not already. However, I certainly don't recommend that they reduce their intake if they're taking it kind of a moderate amount. So if you have patients like this one who's having 1 to 2 cups of coffee or espressos a day, I think that's perfectly reasonable for them to stay on. However, any degree of alcohol reduction will be beneficial. So I think here are the take-home points really, that moderate exercise is beneficial for atrial fibrillation, but intense endurance athletics may be harmful in men, but probably protective in women for reasons that are not totally clear. Caffeine use is not associated with any risk of atrial fibrillation, but alcohol is strongly associated, and certainly cutting back or even being completely abstinent is beneficial if their goal is to maintain sinus rhythm. All right, so our next case, so this is a 68-year-old man with a history of esophageal strictures, status post-esophageal dilatations, a history of hypertension who's coming in with multiple embolic strokes and is found to have newly diagnosed atrial fibrillation. He has good functional capacity, has no anginal symptoms. He's been cleared by neurology to start anticoagulation, is currently on apixaban 5 milligrams twice daily and metoprolol 50 milligrams twice daily. On exam, he is normotensive with a well rate control. He has a right-sided facial droop, but no other focal neurologic deficits. He is euvolemic without other signs of heart failure. His transthoracic echocardiogram shows moderate left ventricular dysfunction without any valvular abnormalities, and the left ventricular function has worsened significantly from 1 year before. So what's the next best management step? A, ischemic testing with angiography. B, ischemic evaluation with stress testing. C, no further testing, continuation of metoprolol and apixaban. D, transesophageal echocardiography and cardioversion. Or E, cardiac CT and cardioversion. All right, perfect. A nice mix of everything. And so I would say E, I think, is the right answer here. I think the reason not to do a T in this patient is with his esophageal history. We do certainly worry about that, and we'll get to some of those points here. And then from an ischemic testing perspective, I think our pre-test probability for ischemia is quite low in this scenario. He has no symptoms otherwise, and it's very likely that this is AFib related. Certainly, as the LV function persists despite being back in sinus rhythm, then I think it'd be very reasonable to pursue an ischemic evaluation. However, at this point, I think really trying to get him out of atrial fibrillation probably makes the most sense. So I think the things I want to highlight here are really about TE. The majority of thrombi seen in patients with atrial fibrillation are seen in the left atrial appendage. The structure is very poorly seen on transthoracic echocardiography, and TE for a long time had been considered the gold standard. There is a risk for embolism with cardioversion if the patient has not been adequately anticoagulated, unless the AF onset is very clearly acute within the prior 48 hours. So current guidelines would recommend assessing the left atrial appendage prior to cardioversion in this patient specifically. I think TE, however, you need to remember is an invasive procedure, significant risk of aspiration or pharyngeal and esophageal trauma. It also happens to be a relatively unpleasant test for many patients, and this is coming from someone who does a lot of TEs. Remember, your patients have to be NPO and to avoid aspiration, which may seem obvious, though you'll be shocked how often patients will be asked to do a TE and the patient is eating breakfast. The following are really the absolute contraindications. If your patient's neutropenic, we cannot put a probe into their esophagus. If they have active esophagitis, also we won't want to be doing a TE. Any type of recent esophageal surgery or radiation, usually within 6 months. We can certainly do TEs in patients with small varices, grade 1. We usually want the platelets to be more than 50. And then any patient with unexplained dysphagia really should be worked up first. Doesn't necessarily need to be an EGD. Sometimes a barium is smaller, or even just a discussion with their gastroenterologist is a reasonable option. I think importantly, a history of esophageal strictures is important to identify. And really, we would want to be able to either talk with an endoscopist or have a recent EGD to look at to make sure that we can move forward safely, particularly if they have new symptoms. Since TE is invasive and relatively unpleasant for many of patients, there was a lot of interest in using cardiac CT even before the pandemic. With the pandemic and the goal to avoid some of these aerosol generating procedures, I think cardiac CT grew significantly. So cardiac CT for left atrial thrombus is a gated study, does require contrast, but it's much less invasive. So really, how good is cardiac CT at ruling out left atrial thrombus? It's actually really good. So there's a large meta-analysis comparing cardiac CT to TE. The sensitivity was 98% and the specificity was around 100%. So overall, a really, really good, well-performing test. That said, these are specialized imaging techniques that need to be used. So you really want to image late in the contrast as opposed to early. And you want to make sure that your center feels comfortable doing this. Though really any center that has the capability to do gated cardiac CT should also be able to do a left atrial appendage study. So in general, the take point here, your patient does need to be, this is a really good way to assess the left atrial appendage before, particularly if there's anything where you may be worried about putting in a TE probe. It doesn't have to be done immediately beforehand, so you could get the cardiac CT the day before and then cardiovert the next day, provided that they're fully anticoagulated at the time in between. So getting back to this case, I think why consider a rhythm control strategy in this patient? I think as all of us had beaten into our heads over time, the AFFIRM trial really suggested no additional clinical benefit to rhythm control over rate control. I think the important caveats, however, in AFFIRM is that majority of the patients had a normal EF, and a large proportion of the patients who were in the rhythm control arm were actually not anticoagulated. In previous trials of a sicker population with more patients with lower EFs, there was data suggesting that rhythm control was associated with functional improvements as well as improvement in LV function. I think the idea that pursuing a rhythm control strategy is beneficial for those with low EFs was very clearly demonstrated in the CASTLE AF trial, which is now about 6 years old. So this is data from the CASTLE AF trial. So this is 360 patients with an ejection fraction of less than 35% with class 2 or worse symptoms on optimal medical therapy who had atrial fibrillation and were randomized to catheter ablation versus optimal medical therapy with rate control. What they found that there was a 36% relative risk reduction and a 16% absolute risk reduction in the primary endpoint of death or heart failure. And importantly, the benefit was seen both in mortality as well as heart failure hospitalization separately. In addition, there were significant improvements in ejection fraction, 6-minute walk distance, and quality of life. And importantly, for those who underwent AF ablation, they still had about 25% of burden of AF, but it was much lower in the patient in the medical therapy group who had about 60% burden. So a lot of the benefit probably has to do with how much atrial fibrillation you're having. And I think the main take home here is that catheter ablation in patients with low EF was associated with improved outcomes, and particularly in a patient who has a high burden of atrial fibrillation, a very reasonable strategy to add on to our armamentarium to improve the overall outcomes. So in 2020, I think the bar got even lower for pursuing an upfront rhythm control strategy. So this is the East AFNet trial. They took 2,800 patients, so a relatively large study, with atrial fibrillation diagnosed within 1 year, though the median time to diagnosis was about 36 days. And they randomized these patients with new onset atrial fibrillation to rhythm control versus usual care, which is rhythm control only for symptoms. Rhythm control could be either medications or catheter ablation. Only about 20% were treated with ablation. They were followed for 5 years. The endpoint was a composite outcome of death from cardiovascular cause, stroke, or cardiovascular hospitalization. Of note that CHA2DS2-VASc in this group was around 3, and only about 28% had class 2 heart failure symptoms, or an EF less than 50%. So in general, a much healthier population than in CASTLE-AF that I showed earlier. So what they found here was that there was a 21% relative risk reduction in the primary outcome. There was no difference in ejection fraction. There was no difference in the overall primary safety outcome. However, there were higher rates of serious adverse events related to rhythm control, but they were mainly driven by the toxic risk of medication-related effects, particularly drug-induced bradycardia. The risk of tamponade and major bleeding with ablation were really quite low, 0.2% for tamponade and 0.4% for major bleeding. I think since the major serious adverse events were due to medication effects and the risk for procedural complications were quite low, this could really argue that upfront catheter ablation might perhaps be even more favorable. So where do we stand in 2024? I think I would strongly consider a rhythm control strategy in patients with recently diagnosed LV dysfunction and atrial fibrillation. I think in patients with symptomatic heart failure on optical medical therapy with a high burden of atrial fibrillation, ablation is pretty reasonable. I think if you're going to pursue a rhythm control strategy, catheter ablation is probably more effective than oral antiarrhythmic strategy. I don't think any of us are ready to recommend an ablation strategy upfront for all comers with new onset AF, but I think with CASTLE-AF and the EAST-AFNet study, the bar for upfront ablation is really getting lower and lower. So while you may all meet patients in the inpatient setting with new onset atrial fibrillation, I think it is important really to make sure that they get tied in with cardiology or even just the electrophysiologist relatively quickly, given the way the field is moving forward. So this patient was successfully cardioverted. The CT was unrevealing. A repeat echocardiogram 3 months later showed resolution of the LV function. He was not interested in any rhythm control strategies. He remained on metoprolol and apixaban with outstanding compliance. However, 1 year later, developed a lower GI bleed without a clear identifiable source requiring hospitalization and multiple transfusions. So what's the next best management step? Transition from apixaban to rivaroxaban. B, transition from apixaban to aspirin 81 milligrams daily. C, transition from apixaban to dose-adjusted warfarin for an INR of 2 to 3. D, stop anticoagulation completely. Or E, stop anticoagulation and refer for a left atrial appendage occlusion. All right, everyone clearly is up to date with left atrial appendage occlusion. So really, this is indeed the correct answer. Apixaban is probably the lowest bleeding risk of all the DOACs, so it doesn't make a ton of sense to transition from the apixaban to rivaroxaban. I think in the era pre-Watchman or other left atrial appendage occlusion devices, aspirin and no anticoagulation would have been a reasonable conversation. Warfarin in general is more bleeding risk associated with apixaban, so I don't think that C makes a lot of sense either. And E really, I think, is the right answer here. So I think the left atrial appendage, as we discussed earlier, really is the major source of thrombi in patients with atrial fibrillation. And the idea of ligating the left atrial appendage has been something that's been utilized in cardiac surgery for many, many, many years. And we're now able to actually percutaneously occlude the left atrial appendage to reduce the risk of stroke with transcatheter left atrial appendage closure. And really, there are 2 devices that are currently available, the Watchman device and the Amulet device. Both are FDA approved, and they've shown to have similar stroke rates when compared to anticoagulation. So just as a reminder, these devices can be considered in patients who have a CHA2DS2-VASc of 2 or more. An appropriate rationale for forward-going anticoagulation. I think patient preference is typically not felt to be an appropriate indication given the procedural risk, and really bleeding risk is going to be the main consideration. The final thing to remember, in general, patients ought to be candidates for 6 weeks of anticoagulation, given that this is the way that this was initially studied in the trials. I think that said, the device probably is best for patients who can't tolerate anticoagulation at all. While the risk of device thrombosis is markedly lower in those on some type of antithrombotic therapy, if you're looking at about 7% risk in all comers, and about 80 to 90% lower with either DAPT or anticoagulation, there is increasing amounts of evidence that it can be done safely and still provides the benefits in these patients. In the real world, I think despite FDA indications, about 70% of patients who undergo a left atrial appendage occlusion aren't actually treated with anticoagulation. And in those treated, the yearly stroke risk is quite low, 1%, 1%. The patients who have an average CHA2DS2-VASc score of around 4 to 5. So even among patients who can't tolerate any degree of anticoagulation, this is still going to be a good option. So what are some practical considerations when thinking about referring patients? First, think of referring patients who have a CHADS VASc of 2 or greater and really can't tolerate anticoagulation. In general, procedural planning is going to be done with either cardiac CT or TE, although CT is increasingly becoming the primary modality. After device placement, TE, and often multiple TEs, although sometimes CT will be used to kind of look to see how well the seal has been achieved. The benefit, remember, is not immediate and it's rarely done acutely. So this isn't really something that should be considered as an inpatient. But again, it's best to kind of schedule this for outpatient follow-up after their index hospitalization with a bleeding event. Like any procedure, there's some risk associated with it. The procedural complication rate with the newest generation devices is around 0.5% compared to around 2% for the first generation devices. So in general, really quite a low risk procedure. So getting back to the patient that I presented earlier, given that he can't tolerate anticoagulation, he was referred for left atrial appendage occlusion. He did well, had a device placed, was put on dual antiplatelet therapy for 6 weeks without any bleeding event, and hasn't had any recurrent ischemic events as well. All right, so our next case is a 67-year-old man with a history of hypertension, well controlled on lisinopril and amlodipine, and diabetes, presenting for an elective knee replacement. On post-op day 3, he's noted to have an irregular pulse, though asymptomatic. A 12-lead electrocardiogram shows sinus rhythm. Over the next 24 hours, however, he's placed on telemetry and is noted to have paroxysmal atrial fibrillation, with 3 episodes of atrial fibrillation, each lasting around 30 to 60 minutes. On exam, his pulse is 86, blood pressure is 130/7 G2, and otherwise unremarkable. His EKG, when in sinus, is unrevealing, and his transthoracic echocardiogram is normal, with only a mildly dilated left atrium. So what's the next best management step? A, initiate a beta blocker. B, initiate beta blocker and aspirin. C, discharge home without any changes. Or D, initiate beta blocker and anticoagulation. Good. So I think D is really the correct answer here. And really, this question is getting around what do we do about a post-op atrial fibrillation? So post-op atrial fibrillation has been studied a lot. I think what we know is that it's relatively common. About 10% of patients undergoing non-cardiac surgery will have atrial fibrillation. I think for a long time, many felt that this was benign and self-limiting. However, it's been really well studied. So we have around 30 studies with more than 2 million patients. And what we know is that there's around a twofold increased risk of stroke with post-op atrial fibrillation. So if you look at people with post-op atrial fibrillation from a non-cardiac surgery, their risk of stroke in the long term looks pretty similar to patients who have run-of-the-mill non-post-op atrial fibrillation. In addition, there's around a twofold mortality increase with post-op atrial fibrillation. Again, this looks relatively similar. And so overall, despite the fact that we used to think that this was just a benign entity, having post-op atrial fibrillation is essentially the same as having atrial fibrillation not in the setting of a surgery. So I think it's important for us to think about post-op atrial fibrillation just like a patient who has run-of-the-mill atrial fibrillation. You really want to look at their thromboembolic risk and use that to help you guide whether or not they should be anticoagulated or not. So just some take-home points, really you want to look at the risk of stroke with postoperative AFib, really the similar way that you would look at the risk of atrial fibrillation in a patient who's not post-op, and really strongly consider anticoagulation based on the CHADS VASc score, I think regardless of duration and postoperative status. So he had a CHADS VASc of 3. Given that it seemingly occurred while asymptomatic and his clinical illness was improving, the decision was made to start him under Roxban, as we discussed. All right, so the next case here is a 74-year-old man with a long-standing history of atrial fibrillation, coming in with acute decompensated heart failure. Extensive AF history. He's had 4 prior AF ablations, all have failed. He's currently being managed on amiodarone 200 milligrams daily, metoprolol 200 milligrams daily, verapamil 360 milligrams daily, and digoxin 0.125. He's normotensive and hypoxic. On exam, he's irregular without murmurs. His jugular venous pressure is elevated, and he clearly has signs of heart failure. Electrocardiogram shows AF with ventricular rates in the 140s. His transthoracic echocardiogram shows a reduction in left ventricular function with massive biatrial enlargement despite a recent negative ischemic evaluation, and thyroid function and testing is normal. So what's the next best step? A, IV furosemide continuing all of his remaining medications. B, IV furosemide continuing all of his remaining meds except his calcium channel blocker. C, cardioversion. Or D, EP consult for AV junctional ablation and pacemaker. Perfect. So I think B, IB diuretics, and holding his calcium channel blocker is the right move here. Right now, as ventricular dysfunction, you really don't want to exacerbate that with the negative negative effects of an inotrope. You don't really want to cardiovert this patient right now. He's clearly in active heart failure, and the likelihood that he'll go right back into atrial fibrillation is exceedingly high. I think an AV junctional ablation and pacemaker is reasonable. However, a lot of this could just be in the acute setting. So it may be that once you get him euvolemic, you may actually be able to rate control him more adequately. Though certainly, if he continues to be in rapid atrial fibrillation despite normalization of his filling pressures, or if as you can't diurese him because he's in rapid atrial fibrillation, I think these would be a reason to consider D. But in general, at this point, I think in the early phase of the disease process, using IV diuresis probably makes the most sense. So IV diuresis is implemented effectively. His verapamil is stopped. Overnight, his ventricular rates improve, but he's noted to have a 4-second pause when he converts from AFib to sinus while asleep. Once awake, he returns to ventricular rates of 140s to 150s. So what's the next best management step here? A, cardioversion. B, EP request for repeat ablation. C, EP request for permanent pacemaker implantation. D, EP request for pacemaker implantation with AV junctional ablation. Perfect. All right, so I think I gave that one away, but I agree, D is the correct answer there. So I think really the question about pacemakers and atrial fibrillation, remember, pacemakers are really only beneficial for slow heart rhythms. So the times to think about a pacemaker are when you're dealing with slow heart rhythms. The patients in atrial fibrillation with rapid rhythms, rapid rates, there's really no role for pacemaker therapy. So in general, pacemakers should be considered in patients with high-grade AV block and awake, symptom-free patients with atrial fibrillation and bradycardia, with one or more pauses of at least 5 seconds or longer. So we'll take longer pauses than patients with atrial fibrillation with sinus rhythm, which is 3 seconds. After a catheter ablation, the AV junction, and permanent atrial fibrillation with symptomatic bradycardia. So in this setting, the patient was clearly having both rapid rates and then going slow. So it really makes it difficult to give additional rate control therapy when he's also having 4-second pauses. Hence the rationale for a AV junctional ablation along with a concomitant pacemaker replacement. So I think that brings us to the end. So I think the take-home points really are that advanced age alone isn't a contraindication for anticoagulation. And you really want to look at the patient in front of you and look what their risk factors are and really make a decision based on that patient who's sitting in front of you and not use age alone to help decide one way. Next thing, DOACs can definitely be used safely in patients with bioprosthetic valves. Just remember, you shouldn't use it in that early postoperative time period. And if the initial indication is mitral stenosis, you really don't want to use it there. Cardiac CT is a reasonable alternative to TE to exclude left atrial appendage thrombus. So if you're patients who you're worried about doing a TE in, or even just for timing purposes, you want to get the TE, the cardiac CT the day before, it's a really nice option to use. I think strongly consider a rhythm control strategy in patients with heart failure with reduced ejection fraction on optimal guideline-directed medical therapy who have a high burden of atrial fibrillation, and even in relatively healthy patients who have new onset atrial fibrillation. Alcohol, but not caffeine cessation, will prevent recurrent atrial fibrillation. Strongly consider left atrial appendage occlusion in patients who can't tolerate anticoagulation. Remember that the CHADS VAS score is going to be the most important consideration when we're looking at patients who have postoperative AFib. You really want to think about post-op AFib as the same as run-of-the-mill AFib. And then finally, pacemaker therapy should really only be considered in patients with a concomitant significant bradyarrhythmias or those undergoing AV junction ablation. And I think I made it with some time for questions. So happy to take any questions.
Oh, excellent. Wonderful talk, Dr. Sun. Thank you very much. We do, in fact, have lots of questions for you, so that's great. Starting off at the top, a couple of attendees are just wondering your approach when you're dealing with transient AFib due to sepsis or alcohol withdrawal. Do you tend to anticoagulate those individuals long term?
Yeah, I mean, I think you have to think about because you want to tailor the risk for each patient. I think if given the bleeding risk is relatively low with direct oral anticoagulants these days, I think if their thromboembolic risk is really high, I think you certainly would tend towards anticoagulation. I think if you're on the fence, I personally would prefer to be anticoagulated. That's often the conversation I have with patients. I don't think it's quite reasonable to consider a bleeding event and a stroke to be equal, even though numerically the same, right? I think the impact of lifestyle of a bleeding event, it's hospitalization, maybe some additional, days in the hospital with some transfusions, as opposed to, a life potentially debilitating illness, debilitating from your functional capacity from a stroke. So for me, I personally would prefer not to have a stroke and would rather have a bleeding event. But I think when they're borderline cases, I think you have that conversation with patients. But I still think that in general, you should treat those patients like other, AF for other reasons, because unless it's a severe episode, most likely they're going to have atrial fibrillation at some other point. You've just managed to unmask it during that hospitalization.
Sure. On the other side of that coin, what about individuals who have been treated with an ablation and they have no recurrence of AFib? Do you withdraw the beta blocker at that point?
Yeah, I mean, so I would say that I think the question is how successful are AF ablations? I think best case scenario, we're still talking only 75, 80% success rates, even with relatively modern technologies. And so, if they're having 20% risk of recurrent atrial fibrillation, I think you have to think about what their thromboembolic risk is. So, very high CHADS back with a prior stroke after ablation. I don't really care if they have no atrial fibrillation. I'm probably going to still keep those patients on anticoagulation. My personal preference, again, I think this is guided by my own preferences, but I would say that, if their CHADS VASC is elevated, I think you have a conversation with them. If the patient really wants to come off atrial fibrillation, come off anticoagulation, and their CHADS VASC is relatively low, I think this is really one of those times for shared decision making where you have a conversation with the patient. I think that there are limited situations for wearable devices, but I think that may be a situation where a wearable device with a well documented AF algorithm might be beneficial, like an Apple Watch, if the patient really wants to come off anticoagulation. But if they're tolerating it just fine, I would say I would just keep you on anticoagulation. But really, if they have a strong feeling to come off, then I think you can have a conversation if their CHADS VASC risk is relatively low.
Got it. It seems like your teaching point about the metabolic derangements was very well received, and there were a few questions along those lines in terms of how you prioritize replacing magnesium. Do you have a target for magnesium or potassium? And then when you do need to use diltiazem in those cases for rapid AFib, how long do you keep them on that added agent?
Yeah, I would say I would normalize it. The problem is that serum magnesium doesn't really reflect total body magnesium. And so, that's probably the reason why it's very difficult to make people hypermagnesiemic and make them toxic from magnesium. So, I would try to get them up to 2 if you can. Certainly giving them, 2 to 4 grams of magnesium is a reasonable option up front. It's highly unlikely that you're going to make them toxic. And I would say potassium, the same, kind of normalize them. I think the important thing here is that there's a lot of anxiety that comes with atrial fibrillation with the rapid rates. The number of patients who don't tolerate atrial fibrillation well is exceedingly low. For the vast majority of patients, when you slow their heart rates down, that actually improves their diastolic filling time and improves their blood pressure. So, unless the patient has, hypertrophic cardiomyopathy, severe aortic stenosis, severe mitral stenosis, severe pulmonary hypertension, severe left ventricular dysfunction, most patients are going to tolerate atrial fibrillation with rapid ventricular rates reasonably well. Again, take the analog of a patient who has in sinus tachycardia from sepsis at 120, 130. They're fine. They're going to be totally, I would say, don't worry about it so much and treat everything else. So normalize everything. Don't worry about the rates and just be patient. It's a lot about just being patient. If you still need to add on a calcium channel blocker, I think you have to wait and see as they resolve. I think if their rates are fine and they're in atrial fibrillation, I think I would leave them on both. You may want to get a sense of what their heart rates look like when they're in sinus rhythm. So, maybe find an old EKG from an outpatient setting if they're, sinus bradycardia at 550 on their home beta blocker. That may be someone who, when they're more stable, you might want to stop the calcium channel blocker to see how they do, for fear that when they convert back into sinus rhythm, they may be, sinus brady in the 30s. But in general, I think if they're tolerating it just fine and their resting heart rates in the 80s in sinus, I would probably just leave them on beta blocker and calcium channel blocker and kind of reassess as an outpatient.
There were are a few questions asking about some potential drug adverse effects. One, with the amiodarone in the hospital when you're starting it, how much of a workup do you need to do before you add it on? Are you doing thyroid, liver function test? And then with beta blockers, are you seeing quite a bit of bronchospasm?
Yeah, so amiodarone, I think most of the toxicities we see with amiodarone are all chronic amiodarone use. So, monitoring liver, thyroid, pulmonary toxicities are when you're considering using this in the, long-term phase. I think you probably want to get something at some point to be starting. It doesn't have to be necessary before you start it. It's not like you'll give amiodarone, you'll develop toxicity immediately. So at some point during that hospitalization, probably good to get thyroid function and liver function testing. I think the major considerations for amiodarone are the cardioembolic risk. So if you do pharmacologically convert them from AF to sinus and they haven't been appropriately anticoagulated, it needs to be something that you need to think about. Certainly no data that that's any different than when the patient cardioverts on their own, although I think it's this idea of first do no harm. We don't want to actively do something to someone, potentially cause harm, as opposed to if they just do it themselves. I think the other important things are, oral amiodarone is extremely bioavailable, so you don't necessarily need to give a lot of you don't necessarily have to use IV amiodarone. So for a lot of patients, if you're trying to use it chronically, subacutely to slow the heart rate down, you can load orally, and it's just as effective as giving it intravenously. For beta blockers, I would say bronchospasm is really quite uncommon among patients with beta blockers. If they have severe asthma, I think that's the one caveat. But even patients who have significant chronic obstructive pulmonary disease can usually tolerate beta blockers well. If you're worried about it, that may be one where you choose something like bisoprolol or atenolol, just because they tend to be a little bit more cardioselective. But in general, it's relatively uncommon.
For individuals with a left atrial thrombus, is there an anticoagulant of choice?
I think it depends on what they're on. I think if they have been on no therapy, I would say we just put them on any anticoagulant. If they are on Eliquis or Apixaban or rivaroxaban, in general, I don't think there's no head-to-head data, but if you look at the bleeding rates, the bleeding rates are higher with dabigatran and bleeding rates are higher with warfarin. So we empirically think that those may be more potent anticoagulants. So occasionally you'll see people intensify from apixaban or rivaroxaban to dabigatran. I would say in general, warfarin is probably the most potent. So if we saw a clot on apixaban, we would probably intensify to warfarin therapy. But if they're not on anything, I think you can choose any anticoagulants.
Great. Any guidance in terms of how soon to bring in a cardiologist with newly diagnosed AFib?
I would say in the inpatient setting, I think if it's not their primary driver for being in the hospital, I think that you should stabilize them, make a decision that I think an outpatient evaluation is perfectly fine. Again, I don't think we're going to be rushing to do anything in the acute setting if it's not the primary driver of their illness. If you think it's the primary driver of their primary presentation, they're in new heart failure with nuanced atrial fibrillation, I think that's a reasonable reason to get us involved so that we can help facilitate, should we be, cardioverting them, moving this up front? Are we missing something else? And so I would think about it that way. We see a lot of bystander atrial fibrillation, in which case I don't think necessarily that's something to rush for us to be aggressive up in the hospital. But I think it's whether or not it's the primary driver for the index presentation, I think those would be the major drivers to decide whether or not we need to be involved. Also, of course, if you're struggling with rate control, they're having tachybrady, they're very fast on multiple agents. I think those are things to think about.
So a couple of people were responding to your question, your teaching about sort of the bleeding versus clotting risk. One question came in, if there's a debate with surgeons about using a full dose DOAC for someone who's postoperative status, how do you sort of have that conversation and make a decision about whether or not to do the full dose versus lower dose for anticoagulation? Yeah,
I would say in general, if you're going to do it, you should just do it. There's relatively good data demonstrating that if you dose-reduced anticoagulants for not a good reason, right? So if they haven't met the manufacturer guideline reductions for apixaban, for instance, that you actually don't reduce bleeding in large populations, then you actually increase the risk of stroke and the systemic embolism. So I think the question is, if you think they should be anticoagulated, you should anticoagulate them. From a post-operative perspective, remember the daily risk of stroke is relatively low, right? So if they're worried from a post-operative bleeding, they want to wait a couple of days for things to settle out. the daily risk of a stroke during that time period is really quite low. Of course, if they just had a stroke, then those are the things you need to think about. So I think those are the things to think about. In general, when we say we'll start anticoagulation whenever the surgeons feel comfortable, for the most part, they're usually comfortable within a couple of days after the surgery, and that's fine. Most orthopedic surgeons are actually starting them relatively early on to help prevent DVTs, and so in general, the risk of bleeding complications is relatively low. But I think important to remember the acute need for anticoagulation is relatively low. It's much more of a chronic, longer-term decision.
Okay, and I'll just ask very quickly, cardiac CT, will we see more of it? Some people are saying that they haven't seen it a lot in their hospitals.
You will see more of it. From a patient perspective, it's much nicer. As long as they can get contrast, if you don't have to have a probe put down your esophagus and get anesthesia, it's much nicer. It's much easier to do, much less resource intensive in general, because it's just like getting a CT scan. So I think as gated cardiac CT gets more and more common, you'll see this much more commonly. If you had a choice as a patient, if I had a choice as a patient, I could get either a CT or a TE. I would definitely choose a CT, and I make my livelihood doing TE. So.
Well, thank you very much, Dr. Sun. That was wonderful.